Welcome to SLP Nerdcast, your favorite professional resource for evidence-based practice in speech-language pathology. I'm Kate Granbois.
And I'm Amy Wonka. We are both speech-language pathologists working in the field and co-founders of SLP Nerdcast.
Each episode of this podcast is a course offered for ASHA CEUs. Our podcast audio courses are here to help you level up your knowledge and earn those professional development hours that you need. This course, plus the corresponding short post-test, is equal to 1 certificate of attendance. To earn CEUs today and take the post-test after this session, follow the link provided in the show notes or head to slpnerdcast.com.
Before we get started, one quick disclaimer. Our courses are not meant to replace clinical advice. We do not endorse products, procedures, or other services mentioned by our guests unless otherwise specified.
We hope you enjoy the course.
Are you an SLP or related professional? The SLP Nerdcast Unlimited subscription gives members access to over 100 courses offered for ASHA CEUs and certificates of attendance. With SLP Nerdcast membership, you can earn unlimited CEUs all year at any time. SLP Nerdcast courses are unique, evidence-based, with a focus on information that is useful. When you join SLP Nerdcast as a member, you'll have access to the best online platform for continuing education in speech and language pathology. Join as a member today and save 10% using code NERDCASTER10. The link for membership is in the show notes.
Hello, everyone. Welcome to SLP Nerdcast. We are very excited to welcome our guests today, Jen Willis and Chris Russell. Welcome, Jen and Chris.
Thank you so much.
Happy to be here.
Now, Jen and Chris, you are here to discuss AAC considerations for students with CVI. And before we get started, can you just tell us a little bit about yourselves?
Jen, you want to go first?
Fight over it.
Sure thing. So my name is Jen Willis, and I am a teacher of the deaf by trade. But I've been working with students who are deaf-blind for a little over 15 years now. And I started studying CVI, cortical visual impairment, about 6 years ago, and have what formerly was identified as the Perkins-Roman endorsement in CVI, which was just something that sort of stated that you have efficiency in assessing students who have CVI.
And I'm Chris. I am by trade a teacher of students with visual impairments, or TVI, and a teacher of students with multiple disabilities. I worked as a classroom teacher at a school for the blind for around 6 years. And then for about 8 years, I worked as the project coordinator of the New York Deaf Blind Project. Wherever you're listening from, every state has a state deaf blind project, which is funded by the U.S. Department of Education and basically provides coaching and training to any professionals or families of kids who have both vision and hearing loss. And through that work, I met Jen, and we recognized a common need that we were both seeing in our respective states on kids with CVI, cortical visual impairment. And we just started diving into this work based on the kids that we were seeing and the collaboration that we were doing with speech pathologists and educators and families in our state. So yeah, that's me. Now I'm actually working as a teacher in a pediatric ICU in New York City, in the New York City Department of Education hospital schools.
That sounds fascinating. I already have 1,000 questions for you just about that, but that's not what we're here to talk about. Our actual topic for today is something that Amy and I are really excited about. As a lot of our listeners know, Amy and I have professionally worked within the field of AAC for years. And yet this topic of CVI always just feels like this intimidating, nebulous, mysterious topic that I was saying before we hit the record button, I know just enough about to know that I know absolutely nothing. And so as we go through the conversation today, our hope is that everyone listening walks away with a deeper understanding. It feels a little less intimidating. And at the very least, we know what direction to go in and what additional resources are available. Before we get into all of the really fun conversations, I do need to read our learning objectives and disclosures, and I will get through those as quickly as I can. Learning objective number 1, list at least 3 characteristics of CVI. Learning objective number 2, list 2 reasons why SLPs working in AAC should be familiar with CVI. And learning objective number 3, identify 3 considerations when using the communication matrix with a person who has CVI. Disclosures, Jen's financial disclosures. Jen has no financial relationships to disclose. Jen's non-financial disclosures. Jen has no non-financial relationships to disclose. Chris's financial disclosures. Chris has no financial relationships to disclose. Chris's non-financial disclosures. Chris has no non-financial relationships to disclose. Kate's financial disclosures. That's me. I am the owner and founder of Grandvois Therapy and Consulting and co-founder of SLP Nerdcast. My non-financial disclosures, I'm a member of ASHA CEUs 12 and serve on the AAC Advisory Group for Massachusetts Advocates for Children. I'm also a member of the Berkshire Association for Behavior Analysis and Therapy.
Amy, that's me. My financial disclosures are that I am an employee of a public school system and co-founder of SLP Nerdcast. And my non-financial disclosures are that I'm a member of ASHA Special Interest Group 12, and I also participate in the AAC Advisory Group for Massachusetts Advocates for Children. All right, Jen and Chris, why don't you start us off by just telling us a little bit about the first learning objective? So what is CVI?
So I'll talk to you guys a little bit about CVI first. And once we dig into that sort of intersection of CVI and communication and assessment and some of the tools we've developed, Jen's going to jump in. So first of all, CVI, or cortical visual impairment, is a form of neurological visual impairment. So when you think of visual impairment or blindness, you probably usually think of ocular or eye-related conditions that cause low vision or blindness, right? In cortical visual impairment, what we have typically is a child or individual who has intact, normal, healthy eyes. So the issue is not with the eyes themselves or with the ocular process. It's rather in the processing or interpreting of information that comes in through the eyes in the brain. So it's a neurological visual processing disorder. It's a neurological visual processing disorder with a very wide range of presentation. And it can look very different. If you're not really sure what you're looking at, it can look very different from child to child, because what we have is a presentation along a range of visual functioning, which you can sort of talk about as being more severe, which is more impactful on functional vision or on visual functioning, or not exactly moderate or mild, but less obviously impactful on functional vision or closer to typical visual functioning. That, on the higher level of the range, that's where it can get very difficult if you don't have like a pretty decent amount of experience with these kids. Those are the kids who I think are most often misidentified, underidentified, or even misdiagnosed with conditions like autism, ADHD, learning disabilities, or other, more cognitive processing issues rather than visual processing. So to take a step back, CVI is it's widely accepted as the primary, the largest congenital or childhood cause of visual impairment. We estimate that somewhere between 30 and 50% of kids with visual impairments, the primary visual impairment condition is CVI. That's a pretty significant number. And that's also accepting that we know that CVI is widely underidentified or misidentified. So that's probably one of the first things of why this is important to you, no matter what your role is. If you work with kids who have had any level of neurological impact, from, a history of seizure disorders to cerebral palsy to anoxic brain injury, especially anoxic or hypoxic brain injury around premature birth are the most common causes of CVI. So you see there's a wide range of causes, anything that could really impact the visual processing areas of the brain. And so that's why, if you haven't seen these kids already, continue to work with kids who have a wide variety of processing issues or sensory issues, and you probably will see them. In terms of identifying CVI, CVI is diagnosed based on, it's more of a correlational or informal diagnosis than a strong clinical one, which is why it's honestly often very difficult to obtain a clinical diagnosis, because we're looking at a history of neurological impact, which can be anything from traumatic brain injury to anoxic brain injury around premature birth, and some of the ones I talked about, structural anomalies, some chromosomal disorders, even Rett syndrome or CDKL5, conditions that involve seizure disorders can cause CVI. So the first condition is that we have some level of neurological impact. The second is that we have abnormal visual behaviors, atypical visual behaviors that cannot be explained by an eye exam. So we need to have an eye exam to make sure that the structures inside the eye are healthy and typical, and that what we're observing can't be explained by something going on in the eye. And then finally, the third criteria, which is the kind of observational informal one, is the presence of unique visual behaviors that are specific to CVI. And understanding those unique behaviors is probably the most important thing to understanding CVI. So yeah, did you want, I don't know if do you want me to get into any of the unique behaviors?
I was just about to ask. I don't know what that means.
Definitely. So if you're working with a student, first of all, I would say if you're working with a student who exhibits anything atypical in their vision, even if you're not a vision specialist, you don't have a wide range of experience working with kids with visual impairments, if you see something unusual, don't chalk it up to, oh, it might just be that they have multiple disabilities. It might just be that they have a cognitive issue. It might just be that they have autism. If you see something atypical visually, the first thing to do is rule out that it might be some kind of visual issue. Those include, in general, odd visual behaviors or atypical visual behaviors include holding things closely, looking kind of at a side angle, not looking directly at things, or almost seeming to look past or through things. Any unique visual stimulatory behaviors like eye flicking, in front of lights, stuff like that. Those could be anything. Some of those could be, indicative of an ocular visual impairment. The ones we're looking for in kids with CVI are more specific. So I'm going to give you the 5-minute version of what could also be a full day presentation. I'm going to try really hard to keep it to 5 minutes, just to understand what these characteristic visual behaviors might look like. So there are 10 CVI characteristics, and some people have said, and actually some of the more recent work that's come out on CVI has suggested that we could pick these apart and there could be many, many more characteristics. But I think these 10 kind of, they do kind of summarize everything that you might see in some way or another. So the first one is color preferences, kids with CVI. And before I say, actually, the one disclaimer is that when we look at these characteristics, what we're thinking about is a range of manifestation, right? So what does this look like for kids who are on the more severe side? What does it look like for kids who are sort of in the middle? And then what does it look like for kids who are on the closer to typical vision side? But it's the same characteristic, it just looks different depending on where it is on this range of visual functioning. So, okay. Color preferences. Kids with CVI may exhibit on the severe side only looking at one particular color, or only looking at colors, at objects or targets that have very strong, highly saturated colors. Red, yellow, bright green, bright pink, neon kind of colors are easier for the brain to process than pastels, black and white, grayscale, and so on. So attraction to or interest in or only looking at bright saturated colors. As they make progress along this range, we see kids can look at any color, but you can use color as an adaptation to anchor their visual attention, to get them to look at something. Putting a red piece of tape around the rim of a bowl, right? Or using a particular implement like a toothbrush that's bright red is going to be easier to find in the cup, Okay. Second one is need for or attraction to movement. On the more severe side, a child with CVI may only look at something while it's moving, and once it stops, I can use my highlighter as my target, right? So it's moving, so I'm looking at it, it stops, and it's almost as if it's not there anymore. So only looking at things that move. As they make progress, they can see things that are still and not moving, but movement is helpful at a distance to attract their attention, or movement is useful in order to attract their attention in a more complex setting when things are busier or when the area is more crowded. The third one is visual latency or visual processing time is really just a delay in visual processing, which is different from a delay in cognitive processing. So it's there, I'm not seeing it, I'm not paying attention to it, but if I just wait a few seconds, then I'll start to orient toward it, right? So, and that can obviously, that just decreases over time, or the latency only appears in more complex situations. The fourth one is visual field preferences. This is different from a visual field loss. It's not that the vision is missing in that area, it's that it's easier in one field over another. On the more severe side, we have kids who are only looking at things maybe on the right side or the left side. The typical progression is one peripheral field, then both peripheral fields, then upper, then central, and the lower visual field tends to be difficult for kids with CVI all across the range, right? Which, you know, would have an obvious implication in a school setting where so many things are placed in front of them on the desk, or for, you know, using a high-tech AAC device, you're going to almost definitely need like a gooseneck stand or some sort of a, you know, positioning consideration. 5, difficulty with visual complexity. I'm not going to get super deep into this because there are different types of visual complexity, but basically the world is a very visually complex place. And the world is also very complex in terms of all the sensory information that's coming at us from different angles. And kids with CVI have difficulty dealing with that complexity. So their vision may appear to fluctuate. It looks like maybe sometimes their vision is really good, and then sometimes it's not good. It's not the child's vision that's fluctuating. It's the complexity of the environment around them, of all of the different sensory input, even of the positioning and the stability that they have, say, in their Riften chair, right? Or about the amount of stuff that's in front of them. We're going to get into that when we talk about AAC array, especially. 6, and then the last ones are like, the next 5 are like pretty quick. So 6, need for or attraction to light. So on the more severe side, it may look like light gazing or staring at bright lights, which is kind of what you do when you're in a Riften chair at a 60-degree angle facing a bright light, but or staring at windows. On the more, you know, closer to typical visual functioning side, the light gazing probably stops, but the child benefits from backlighting to enhance their attention. So it's easier to look at something if it's presented on a backlit screen, an iPad or an AAC device. 7, difficulty with distance viewing. Harder to see things that are further away, but not because of the blurring of vision, not because of an acuity issue, but rather because things that are further away are actually more complex. If I'm closer to something, there's less in my array. If I'm further away, now I'm looking at this busy preschool classroom. You know? 8, atypical visual reflexes. There are 2 visual reflexes that we should have: a blink to touch between the eyebrows. If you try it on yourself, it does not work, but it's fun. And then blink to threat, right? Something coming at you. Kids with CVI may have atypical responses or latency or inconsistency in those blink reflexes. Obviously not something we're doing an intervention for, but it's almost like a gauge for the connection between their eyes and their brain. 9, difficulty with visual novelty. It's easier for kids with CVI to see or process information that they're familiar with, whether it's favorite toys or favorite items, or environments that are more familiar. You're going to see a better use of vision. That's one of the reasons I think why kids with CVI often get misdiagnosed with autism, because they tend to show restrictive interests in materials, similar to kids with autism. But it's more because unfamiliar and new information is very difficult for them to process. So it's easier to look at things that are known and familiar, and people. And then the last one is difficulty with visually guided reach. So I'm holding up my cup of water. A child with CVI may have difficulty looking, reaching, and staying in physical contact with the object or target simultaneously. For kids who have difficulty with who are not able to actually initiate a reach for physical reasons, you can think of this as like it's an extension of the complexity issue. It's difficult to use two sensory inputs at the same time, to touch or even to be in tactile contact with a person and use vision at the same time.
I
So that
just
was
learned
10.
I just learned more in 5 minutes than I have learned in my last 15 years as a clinician. That was so helpful. And all I kept thinking while you were going through those points was how easy it must be for some of these characteristics to be misdiagnosed or to be written off as, oh, well, they're just staring out the window because they're bored or they're having a hard time paying attention, or I don't know, write it off, write it off, write it off. I mean, I am kind of floored by
Yeah.
that possibility.
I think it's a really common thing. We see it all the time. And, in my time on the Deaf Blind Project, I spent a lot of time in schools specifically for kids with autism, because a lot of those teachers, when they learned a little bit about CVI, they saw something, or they heard about it, or they attended some training, they started to ask themselves, oh my God, do all these kids have autism? Or do all these kids have CVI? And the answer, of course, is no. But when I did go visit those schools, I did find kids that I had real serious questions about their visual processing. And you could start to pick apart, well, what do visual behaviors that are different or unique look like in autism? And what do they look like in CVI? And it's very different.
Well, and I just think about all of the ways that if we do have a student on our caseload who does have CVI, a lot of our instruction is set up to challenge some of those areas that you talked about unnecessarily, right? So we have people reach for things and show us pictures and give us, coordinate those two systems together. And the barrier actually might not be the learning component. It might be that we're asking them to do something, which is a challenge to their sensory system. Um, I wonder if you can talk to us just a little bit about the CVI range, which is a tool that helps us maybe even better understand these different presentations of how a student with CVI might appear to us as their communication partner.
Yeah. Jen, do you want me to keep going on the CVI tip, or do you want to take CVI range?
Nope, I want you to keep going on the CVI tip. But in response to what Amy was just saying too, one of the also challenges is when teachers or speech language pathologists are writing IEP goals, especially around communication. If they're not familiar with CVI or the modifications that need to be made, oftentimes a communication goal can actually end up being a vision goal. And so that can impact the child's ability to be successful in how it's written.
That's a really good point, Jen. I think that point is one that we're going to come back to when we talk about collaboration. And probably like if there's a giant takeaway that we hope to get to, aside from the specific objectives, it's the importance of collaborating. If you're a speech pathologist, like you really need the information that usually the TVI, but it could be a TOD, teacher of the deaf. It could even be a intervener, a deafblind intervener, or it could even be a teacher, but whoever has that CVI information, you really need it for these kids. And then you, on the other hand, if you're the speech pathologist, you need to impart your sort of AAC and communication wisdom to that person so they understand that this is a balance. It's not, there's always going to be the issue of the speech pathologist wants more language, more icons, more information, a bigger array. The TVI always wants less because it's too much for the child to handle visually. Neither one is right. We have to find something in the middle. And we're going to get into that. And so CVI range, real quick.
I think just super quick, but I also just want people who are listening to this to understand how hard I was shaking my head as Chris was describing the dance between the vocabulary that I, as the speech pathologist, want and that my TVI who I'm collaborating with feels is appropriate. So that's like an ongoing conversation. And I think that's just what it's definitely an ongoing conversation. And it's okay that we come at it with two different perspectives. And part of what's so important is that we have those conversations.
Totally. And, I think hopefully it should be empowering for a speech pathologist to be able to say, like, yeah, I am the expert on this area, but I recognize that, I need to communicate my expertise on this area enough in order for you, being the TVI usually, to tell me what I need to do to modify the design and the presentation, of whatever level of AAC program you're talking about. Yeah, okay. So, all right. So the CVI range really quickly is, it's a functional vision assessment protocol, right? So it is an assessment tool or, form essentially that a TVI usually, or anyone who's providing an assessment, a vision assessment for a student with CVI, can use in order to get a rough score. The score numerically is not as important as the information that you're getting from it, but what it's giving you is it's telling you where on this range of visual functioning is this child with CVI right now, okay? And the range is basically 0 to 10, but there's no such thing as a 0 because there's no such thing as a child with CVI who has no visual functioning. And there's also no such thing as a 10 because you never completely resolve CVI. So it's everything between 0 and 10. 0 to 3 would be considered phase 1. So phase 1 is sort of the most severe impact on visual functioning. Phase 2 is 3 to 7, roughly 3 to 7. And phase 3 is 7 to 10. So phase 3 would be closer to typical visual functioning. We need to know which phase your child is in, which phase the student is in. Getting a specific score is important and helpful, and getting all of this information that we get from the CVI range assessment about specifically how are each of those 10 characteristics I ran through impacting your child's visual functioning. That's what we're getting from the CVI range. But the huge takeaway is the phase that the child is in, because the phase drives the interventions. We have completely unique interventions and unique approaches to intervention for a child in phase 1 versus in phase 2 versus in phase 3. So when Jen gets into talking about some of the materials that we've designed, a lot of those materials and considerations are super distinctive to phase. So we've got ideas for what this means for kids who are over here, in the middle, and over here. And I guess the last thing about the range is that anybody can learn how to use the CVI range and make it one of your, a tool in your toolbox, but only a TVI or an orientation and mobility instructor can provide a functional vision assessment, for the IEP.
And I think if it's possible and you have access to a TVI or a certified orientation and mobility specialist, accessing those resources is probably going to be better than doing it yourself. However, reviewing the assessment tool can just be helpful as an SLP to figure out what's on there and how that might look. I wonder if you guys can talk us just a little bit through maybe some examples of what a student with CVI might be working on with their TVI or with other people in their school environment, and kind of how that might look depending upon which phase they are in.
Tired of talking, Chris? You want me to take over?
No. I just want to make sure I'm not hogging the air.
You are perfectly fine. As Chris said, anybody who has some familiarity with the CVI range can implement it. But it's not, this quick 5-minute chat on what it is and how to use it is of course not going to make you efficient in being able to do it successfully. There are tons of classes online in regards to cortical visual impairment, how to implement the CVI range, reliability in doing so, because it really, two different providers can easily interpret something differently, both in how it's written and what they should be looking at, as well as the presentation in the child and what they are observing. So it's not a quick and dirty type of thing. We've done lots of years of training and experience to become reliable in completing that assessment. So don't go at it alone if you're new. But it really is dependent on the phase of the student. So having that assessment completed is really, if you're a provider working with a child, having a TVI or someone complete the assessment and then utilizing those results to determine how you're going to approach interaction with the child. Students who are in phase 1 are working on vision as a separate task. It is a sole task by itself. They don't have the ability to integrate vision with other actions at that time. So those are going to be your students who are going to be accessing communication materials, either tactually or auditorily, given their access. That could mean a device using motor movement. That could mean tangible symbols and concrete objects that they're using for communication purposes. That's going to mean potentially during story time, just having them sit and listen to a story. We're working on, accessing information totally auditorily, not asking them to both listen to a story and say, look at or interact with pictures in a book, because that's not something they're going to be able to do at that level. Children in phase 2 are just beginning to start integrating, vision and action together. And phase 2 is so large and so complex that we actually break it up into 2 sections, early phase 2 and later phase 2, because what students are capable of doing in those 2 different areas is it can be very different. Our students in early phase 2 are just starting to integrate vision and action together. So that might be just starting to locate familiar objects within a more complex array. Whereas your students in later phase 2 are hopefully starting to have eye-to-object contact and get a little bit more detail in what they're seeing. And those are your students who can start looking at 2D materials, can maybe start with photographs, can maybe start with something on an iPad. So that's really going to impact the choices that are made for communication tools, as well as, what they are able to access and how much they are able to do. There's so many extenuating factors if we're looking at visual fatigue, what else? The complexity of both the materials we're presenting them as well as the environment. And then your phase 3 students are the ones who are better able to integrate vision into function in a more natural fashion. Still not necessarily as someone with typical vision, they're still going to have challenges, but on a more complex level. So they might be able to handle a more high-tech, more complex AAC device, communication system. So yeah, there's the basic.
Just as Jen was saying that, Jen mentioned something super important, which is eye-to-object contact. And she mentioned that sort of in the middle, coming around the middle of phase 2. So you can kind of, if it's a range from 0 to 10, eye-to-object contact kind of starts around 4 or 5 there. And I thought that this is important to mention because I know wherever you are out there listening, you may not have access to a CVI range assessment. You may not even have access to a TVI who is familiar with that, or probably familiar, but who is a reliable evaluator, right? Somebody who has a lot of experience conducting this assessment and, feels comfortable giving you a real score. So the sort of cheat sheet version to understanding where your student is on the CVI range, and at least giving an estimate, which is better than no score at all, is eye-to-object contact. Eye-to-object contact means the ability to look directly at something or fixate on it. So a prolonged fixation is like another way of saying eye-to-object contact. That's different from someone who looks past or through something, or looks indirectly at something, or maybe only looks with their peripheral field, never looks directly at, right? So if your student is not making any eye-to-object contact ever, they never are in any circumstances, they are lower than a 4 on the CVI range. They're either phase 1 or very, very early phase 2. If they're making a little bit of emerging eye-to-object contact, like most of the time they look indirectly or past or through things, But occasionally maybe a favorite thing or something that's super easy to see, like this bright, saturated, colorful thing, you'll see a brief eye to object contact, then it's gone. They're probably around 4 to 5 on the range. If they're making more consistent and prolonged eye to object contact, they're probably a little higher. And if they're showing what's called visual curiosity, which is not just eye to object contact, but literally looking around and exploring the room visually, scanning is the ocular word for it, but it's really like exploring in a visually curious way, then they're probably in phase 3.
I have an unplanned question that
Yay.
could be a not very good question. But I'm thinking about all of the, again, everything you're describing. I'm hearing in my mind all of the dismissive comments that could be coming from a team member. If a speech pathologist is listening to this, reflecting on their own caseload and going, oh my God, this kid that I've been working with is doing this, and I never thought it could be CVI. If someone were to bring this up as a possibility, and again, I'm thinking a lot about the kids who carry an autism diagnosis, who are, in my previous clinical existence, I've written things like poor visual attention. We chalk it up to attention, or we chalk it up to something else. If a speech pathologist is reflecting on their current caseload and wanting to bring this up to the team as a possibility, and get some of these dismissive comments like, oh, it's just their attention. Oh, well, they have autism. Of course they're, some of these, I keep using the word dismissive. I don't have another word, but just belittling the possibility of this.
Yeah.
What arguments could a speech pathologist, or what defenses, or what suggestions or recommendations could someone say in response to that? And I'm asking this question because I anticipate a lot of pushback, because this is kind of this nebulous, poorly understood phenomenon. What would you recommend in that situation when a clinician is faced with this dismissiveness?
I mean, I think we see this all the time, right? So I think everybody probably has a different way of addressing these types of things. So I'll give mine. Maybe Jen, you have a different one too. But usually, what I will say in those circumstances, or if it's me, or if I'm kind of helping somebody else to say this, is to try to make really close observations rather than just pushing back and saying you're wrong or whatever. Try to get really close observation data to say, this is what I'm observing. This is exactly how it looked. This part was unique and really couldn't be explained by such and such. And you don't really have to be a vision expert to do that. If you're someone who has experience working with kids with autism, you know what poor visual attention looks like in kids with autism. And what you're seeing is different from that. So take really close observational data. And an example I can give you, the one that I usually saw when I spent a lot of time at schools for kids with autism, was a child with autism. If you show them something that's of no interest to them, like this pen that's not bright and saturated, they're going to take a quick look and then decide that they're not interested in it. So they may not exhibit, a strong interest and explore it, but they'll take like at least a fleeting look to see what it is. A child with CVI won't even notice that it's there, but may notice that the bright saturated one is there, right? So the restrictive interest is different from the inability to process something visually. It's not even there. Whereas a child with autism will recognize that something is there. They just may not care. They may not show an interest in it. So that's one. I mean, I'm sure that there's others too. Also, like hand flicking, or like anytime you see, I always say this in general, anytime that you see, what is often called self-stimulation behaviors, but what I call sensory recreation and leisure, right? Is like, there's always a reason for it, right? So it's not just like, oh, they're just doing that because that's what they do. No, like they're doing that to balance the sensory input that they're not getting in other ways. So all you have to do is figure out, well, what might that be fulfilling? And what I always try to do is literally just do it myself. I'll just like get in there with the kid and do whatever they're doing and see like, well, what does this feel like? And like, what am I getting from this? And try to figure out like, try to get out of the mindset of, oh, it's just their condition. Jen?
Sensory recreation and leisure is my new favorite term. Thank you.
I love
Yeah.
that too. I was like finding a place to write it down.
Well, I can't claim credit for that. I give you well, I can claim credit for the iteration, but I get the idea from, there's a really great article that comes from our field of vision and deafblindness from the 90s, and it's called Self-Stimulation in the Pursuit of Leisure. And then the subtitle is, I'm okay, but you have a mannerism. And you can look it up. You can find it online. It's really good. And it's all, it's by Robbie Bleha and Kate Moss. And it's all about like reframing the way that we think about sensory stim, right? And that we have sensory stim too. Like I'm, playing with my ring, or like you might be twirling your hair or crossing your legs. And all of those are fulfilling different specific sensory channels, not just input, but like a tactile channel or a proprioceptive channel or a vestibular channel. It's just that the versions that our kids have are not socially informed by, what how we're supposed to behave.
And the link to all of these resources in that article will be in the show notes for anybody who's listening while they drive or what have
It's
you.
like my favorite article, and it's very like family friendly and professional. It's like not an academic article.
For providers, though, it never hurts to ask. I mean, if you have some of those gut instincts and you're just curious and not sure, bringing it up to the team, seeing if there is a TVI that could come in and provide an assessment. I mean, I know they're not going to want tomorrow every child with autism to be getting a vision assessment, often it is the state deafblind projects. I'm on the Maryland DC project. Those of us that have knowledge and experience with children with CVI. So some of those state projects might be able or to provide an assessment or to give you guidance of other professionals who can, because really it is ruling out the vision first can always be a thing. Not dismissing it as just autism, but ruling out the vision gives you that information. And that could be done even if you don't have the assessment, putting some of the modifications in place. What happens if you reduce the array? What happens if you put that child in a non-complex environment and then start providing visual information to them? What happens if you use backlighting or spotlight a toy or an object? Does their vision seem to change? Do their visual reactions differ from what you're seeing in other environments? And then that could be an indication that, yeah, maybe there is a vision impact in this as well.
I love both of your suggestions. Whoa, sorry. Go ahead, Chris.
No, you go ahead.
I was just going to say, I love both of your suggestions. And I do think the idea of, well, just try it. Like, just try using a really bright background color and see what happens. That's not going to hurt anybody. And it might at least give you some helpful data that whether or not you end up with a diagnosis of CVI, it might give you helpful information about your accommodations and teaching procedures. So yeah, I think those are both great suggestions.
And the CVI interventions, or at least adaptations that are related to CVI, we get this all the time too when we do these trainings on CVI, especially. It's like, well, wouldn't that just be helpful for anyone? Like, isn't like using a highlighter just helpful? Like, isn't using a bright saturated color or illuminating something, or like, what isn't lifting, holding something up a little higher better for anybody? Using a slant board. And like Amy, you said, it's not going to hurt to do these adaptations. The difference is that for kids with CVI, it may help anyone, but for kids with CVI, it's the difference between them getting the information or not getting it at all. And you will see that difference. You'll see like, oh, it's a little bit helpful, or maybe like it's a little more efficient, or like, wow, we went from like no access to access.
And I don't want to derail us too much, but I just want to make a quick comment. I think that's something, as a field who is trained to pathologize, as a field who is trained to look for clinical problems, right? That's what we're trained to do. I think in a lot of instances, we forget about the general human condition. So an example I always give is, I write things down. I wouldn't ever go to the grocery store hungry without a list. I'd spend my entire paycheck on delicious cheeses and dark chocolate. That's what I would do. So I have to use all of these strategies to keep myself in line. And it's not because there is clinically a problem. It's because I'm a human. And there are so many things that we can offer our students with disabilities across the board to, help them live their best lives because they're human, not because there is a reason to pathologize that they need an accommodation or support. And I think that's such a great point. I am already feeling like I could ask you guys 10,000 more questions and talk to you for 500 hours. I'm wondering if we could talk a little bit about how this relates to the communication matrix and, specifically through the lens of AAC. Shall we start off maybe by talking a little bit about what the communication matrix is for for individuals in our audience who maybe haven't used it?
So the communication matrix is an amazing tool. It's fantastic. And for those of us who are working with children who are deafblind, especially, it is probably the primary or the best tool that we have for assessing communication in those pre-linguistic communicators, because it goes all the way back to the most foundational, basic actions, gestures, just instinctual responses that a child or an infant will give you. It includes 7 levels of communication, all the way from those pre-intentional, most basic instinctual cries, body gestures, facial expressions, all the way up to abstract language, and hits everything in between. And the thing to really know about the communication matrix is that all children go through these 7 levels of communication. They cover them all. The thing is that they often happen very quickly and before 12 to 18 months of age. So they're often happening before a child is entering school. So they come to school already having a lot of these foundational skills. The problem for our children with complex communication needs is that they are arriving at school needing to be handling higher level content or vocabulary, all of these things, and they haven't necessarily gone through all of these levels of communication yet. And so we often, when they get to school, I actually recently talked to an SLP who told me that in her training, they are taught that really the first thing to go to is, say, a button or a device or something that they can program terminology into, which those terms, those words are abstract language to a child who is pre-linguistic. And essentially, because my heart is with children who are deaf or hard of hearing, many of those children come to school not even having that receptive foundation that our students with auditory access come to school having heard so many words, and they're just needing that support with expressive language. Really conventional, those concrete symbols that we're providing children with, be it through a device, through a button, through tangible symbols, is really level 5 on the communication matrix. There are multiple levels prior to that include just the child using their body and their behaviors to express and communicate something. And it really is having that adult respond to and interpret those behaviors that transitions them from just trying to obtain what they need to get their needs met, obtain something or get away from something, to, oh, now I'm going to direct this at someone else because now my actions, what I'm doing, can have an impact on someone else understanding me. And that starts that back and forth of, now we're having a conversation and then I'm communicating something to someone else. If we don't allow children to go through that stage, if we don't respond to how they are communicating and engaging with others, and we solely rely on an aided way of nope, I'm going to need you to do this action to, that then results in me reinforcing that in some way, it's very possible that disconnect is never going to engage for them to realize that, oh, my instinctual initialization of actions also have meaning, that I can communicate other than when someone assists me with pressing a button or activating a device or choosing certain vocabulary. So that's the importance of the communication matrix and using it as a tool to build communication. Chris?
Yeah, just to add to what Jen was saying, I really think, and I would love to hear Kate and Amy, like, if from the speech pathologist and from your own background perspective, if this makes sense to you, if you've seen this too. But I really think that, in my experience, the main reason that the kids that we have experience working with who have significant, multiple sensory challenges and, lots of stuff going on, the main reason that I see kids not making progress in their expressive communication is because you're providing them with robust abstract systems, and that child doesn't have symbolism yet. They haven't achieved the expressive milestone of symbolism, right? So we talk a lot, this is really big in the field of deaf blindness, sort of the big milestone of symbolism. One of my favorite articles, if you're like interested in other reading, is by Susan Bruce, who is a really big researcher and person in the field of deaf blindness, called The Path to Symbolism. Right. And so what she talks about is how, when you're communicating pre-symbolically, what you're able to experience about is only what's in the moment, right? So the milestone of symbolism and being able to use a symbol to represent another thing, whether it's a concrete symbol or an abstract symbol, whether the most concrete, like I'm using the water bottle cap to express about the water bottle, right? But the water bottle is nowhere near, you can't see it. If I'm able to actually use this cap as a symbol for the water, and she talks about, I love the phrase, she talks about being freed from the constraints of your immediate experience, right? So when you have symbolism, you're able to communicate about things that are outside of your immediate experience. A lot of our kids, especially if they have visual impairments, and even more so if they're deaf-blind or have combined vision and hearing loss, they're so bound to their immediate tactile and haptic experience that the world outside of arm's reach is much, much harder to access, to comprehend, and then to communicate about. We need concrete symbols as a stepping stone between pre-symbolism and symbolism and language. And way too often, what I see is, just using abstract symbols as a whole system for a child who doesn't even have that concrete stepping stone to make the correlation between an immediate experience and an activity, a person, an action, a toy, whatever. So what we really focus on, and probably one of the main things that we've worked on, that Jen and I have worked on with our tool, is to look at what does this mean for kids who are pre-symbolic, for sure, but also who are concrete communicators. They're not ready for, expressively, they're not ready for a super abstract, expansive system. Then from you guys from the speech background, what I always hear is, right, but we want to provide them with exposure to language. Well, we're not talking about limiting their receptive exposure. We want a robust system receptively, but we want to scaffold that with something that is concrete expressively, that meets them where they are and allows them to take that next step up to that huge milestone of being freed from your immediate context, right?
Here times 10,000%.
Seriously.
Is my very informal response to that monologue. And this is something that we've talked about before on this podcast with two researchers, Dr. Kathy Binger and Dr. Jennifer Kent Walsh, who are AAC researchers. If anybody, we'll link that episode in the show notes as well, if you want to dive into this topic a little further. But essentially, just because a device, or just because we have access to these high-tech tools that can turn on the lights and send text messages and provide these really robust, symbolic, abstract language systems, doesn't necessarily mean we should forget about our developmental milestones. And, basically what I learned from them was it's little a, big C. We're here about communication, and, we really need to make sure we're going back to those developmental milestones and meeting a child where they are. I don't know, Amy, if you have anything else you'd like to say about that.
Well, other than my really robust head shaking, no, I mean, I think having been in the field of AAC long, medium, old, since before the advent of iPads in 2012, I think that also was sort of a pivotal shift for SLPs, but also for families. And I think this is important information for SLPs to have, not only so we can do our best work by our clients, but also so that we can counsel family members who may also feel that not going with this really abstract high-tech tool is somehow lesser than, when in fact, if it's an inappropriate match for our client's communication needs and current level, we're not going to get anywhere. It will look fancy on the outside, and on the inside we'll be writing the same IEP goals over and over and over again. It also made me think about Cynthia Kress is a speech language pathologist who has done some work around communication signals. And so for anybody who's listening, that's another place to look, just at teaching some of those early unaided pre-symbolic communication behaviors and moving those toward a more symbolic and consistent system. And I think obviously Kate and I have big feels about all the things you just said.
Big feelings. Here.
Yeah.
I wonder if in our, oh, sorry, Jen, did you have something to say?
I was going to say that, and part of the reason that we created this AAC CVI matrix was because the need for the intersectionality. We saw, if you look at symbolism from just as that of the items that you're choosing or the objects that you're choosing per child for communication purposes, they might be a very realistic object you are choosing, but then you add the CVI piece to it. And the problem with, or the challenge for children with CVI, is that they don't necessarily have that categorical knowledge or that ability to generalize information. So for example, they, a shoe to them might only be the shoe that they wear. That might be to them visually what they recognize as a shoe. They don't necessarily have the generalization ability to realize that other sneakers are also shoes, or that other types of shoes, sandals, flip-flops, all of those also count as shoes. So when we're choosing an item, right, a symbolic item might be a smaller version of a shoe that looks exactly like a tennis shoe to a child with an ocular impairment or with typical vision. But for that child with CVI, they're not making those connections. So now we have to take into account not only the child's level of symbolism, but also their level of vision access in regards to CVI.
And, I know we probably don't have that much time. This would be a whole other tangent to get into, but the whole conversation about core vocabulary as a choice for kids with CVI or with visual impairments in the first place. And everybody, I'm sure, has a lot of feelings about that. But one consideration, without giving too many feelings about it, is that a lot of our kids with sensory impairments, especially significant congenital visual impairment, and definitely deaf blindness, they actually tend to learn fringe vocabulary before core vocabulary. There's a really good recent article by Janice Light, because we don't, we got to listen to a speech pathologist on this one and an AAC person on this topic, but there's a really good Janice Light article from a few years ago.
You want the name?
Oh yeah, you have it? Yeah, cool.
Yes, it is called Core Vocabulary Lists for Young Children and Considerations for Early Language Development, a Narrative Review. And it is by Emily Laubscher, Laubsher, and Janice Light.
And they talk about how core vocabulary and core systems might not be the most appropriate for kids who have restrictive experiences, significantly restrictive life experiences, which is definitely kids who are deafblind, and is probably most kids with CVI who lack access to incidental information and really can't observe those, they're not just going to gather the new vocabulary by observation, because their disability is a disability of observation.
Okay. I like Kate could talk to you for 300 years.
I have so many. I'm holding so many things in my thinking bubble. I'm doing such a good job.
I know. No. So I think in our last 10-ish minutes or so, I would love to hear a little bit more about the specific work that you both did with the communication matrix and what those considerations should be for SLPs who are trying to use the communication matrix with somebody who also has a diagnosis of CVI.
I mean, definitely get the matrix. We will certainly put it out as a link, utilize it. It is hopefully designed as a very user-friendly tool. It contains a ton of resources and background information in the beginning. If you're not familiar with CVI or the communication matrix, it gives you lots of resources that you can access to learn about both of those things individually, as well as then how to intersect and bring them together. And we have outlined it and designed it to be broken down by both phase as well as by levels of communication, pre-linguistic communicators, concrete communicators, and then your proficient abstract communicators. And really, it's a tool to be able to utilize all of the skills or the strategies that we have outlined in the matrix are also defined in the back of the matrix as well. So things that people might not be familiar with, like utilizing touch cues or name cues. For individuals with CVI, visual complexity of faces is a real big thing. And oftentimes you might get a child who's in a school system that has 4 different providers who are all white females with brown shoulder length hair. And the issue is that they cannot distinguish one provider from the other. So like we said, those tools that we use primarily for children who are deafblind can also support other students that might have auditory access. You're pairing those, just giving them additional supports and resources that they can use to help increase their independence and their ability to access the information.
And so what it basically is, it's an intersection of the CVI range score and the communication matrix score. And even if it's a rough estimate, if you have CVI range results and communication matrix results, what we're doing is pairing them together and finding what that intersection is. And it's important to understand that, kids can be in between phases, just as kids can be in between levels of communication. So we want you to look at not like a restrictive definition of where the child is, but more like what's the rough kind of area that they are in their expressive communication development and in their visual functioning with regard to CVI. Once you know that, the majority of the document, if you go in and look at it, the majority of the document is considerations. It's not you must do this. It's bullet pointed. And we actually, instead of bullet points, we use like the little check boxes with the idea that you could go in and check off what are the ones that you want to try or think are most relevant to your student. So if you, for example, your student is in early phase 2 and is a concrete symbolic communicator, meaning that they communicate through tangible symbols, photos, line drawings. They have symbolism, but they need really concrete symbols, not abstract ones. You're going to go to the early phase 2 page, and you're going to look at the middle column for concrete symbolic communicators, and there's all of your considerations. I like to think of this more as a conversational tool than as it's not an assessment. It's a collaborative conversational tool for the team to meet together and talk through, oh yeah, they are around here, so like maybe we should be doing this. And then it's going to inform the way that you design, adapt, and implement AAC for these kids.
And just as somebody who found this on the internet and thought, "Oh my gosh, this is awesome. We've got to find these people and talk to them."
There was
really
a fangirl
is.
moment. There was.
There was.
It happened.
Well, because as somebody who's working with students who both have CVI and are accessing AAC, and I have the great benefit of having a fantastic CVI to work with, fantastic orientation and mobility specialist, but this tool is still really super helpful because they've broken it down by each of the 3 phase chunks, so where you could be in the CVI range into those 3 phases, and then also breaking apart phase 2. And then you just take your communication matrix results and map it onto that. And you say, okay, well, my student is here in like early phase 2 and they're a concrete symbolic communicator. Let me just look through here. And it's super helpful. I don't know if you guys could just give some examples, even just from the work that you've done, for how that might look. So what might it look like if I have that concrete symbolic communicator, and what should I be considering if they're at phase 1 versus if they're like later phase 2 or phase 3? Like how different might my thought process be mapping on their CVI needs?
You want that? You want me to take that?
Sure. Okay. So first, phase 1 is very, very unique because phase 1, you're really not going to feel, I always tell teachers and TVIs, you're not going to feel like you're doing what you're going to feel like you're some sort of like a low vision therapist or something, taking a kid to a quiet room and moving a glow stick around or something like that. So what that means for kids in phase 1 who are AAC users, anything two-dimensional is going to be totally visually inaccessible. That doesn't mean that it can't be accessible by auditory scanning or motor memory. These are options, but rule out visual access to AAC for kids in phase 1. Kids in phase 1 are not looking and doing simultaneously. So vision is not the access point for almost any communication system in phase 1. Kids in phase 2 are starting to integrate their vision and functioning, but two-dimensional material is still going to be very difficult. It's impossible in early phase 2. It's becoming more accessible in later phase 2 once you have that eye to object contact, right? So what you're going to get in phase 2, I think, and I think the biggest consideration, there's lots, but the biggest one I think is considerations to the array of information that's given. So whether that's a low tech or even a no tech array, you know, a light tech array or medium or high, whatever level of AAC you're looking at, think about how busy it is visually and try to make it less busy. So and then, you know, if you're looking at high tech, and then this is later phase 2 and early phase 3 often, some things are very simple adaptations, like a black background on the array. Take away the outlines or borders. You might be thinking, oh, but kids with CVI do well with bright colors, so I'm going to make all the icons red. Well, if you make the background red, the child's no longer looking at the icon. They're just looking at the bright red background. If you make the outline like you have in Zoom, the green outline around me right now, if you have the outline, they're going to be looking at the outline, not the icon, not the target inside of it, right? So the way that we adapt the array and the way that we add things like color and light and reduced, you know, complexity of the information itself, it's all going to depend on sort of, you know, this rough estimate of where the child is, but also on I think complexity is the overarching characteristic. So all of these considerations are going to in some way serve to reduce complexity of the array, of the icon itself, but also even of the background or the presentation where, you know, if I turn my camera right now, you'd see my busy kitchen, right? But I chose to have a non-complex background array instead, so it's less distracting.
I have a question for the SLPs who are listening who don't have access to you, right? So these are SLPs working in a pediatric outpatient setting who maybe don't have a TVI or in private practice, or even in a private school that doesn't have access to a TVI. Are there publicly available resources or other, I don't know, consulting professionals or open access materials or other resources out there that an SLP can reach out to or access if they're now reflecting on their caseload and thinking, oh my goodness gracious, I really need to do X, Y, and Z, but don't have the resources to do so? Where can we send those individuals?
I mean, you can definitely send them to us anyway. I hesitate to say that with your, you know, 5 to 13,000 listeners. But you know, I like, we do field questions and send resources, but there are actually a lot of resources available. There's not a ton on CVI and AAC. There is definitely a ton on CVI. We've recorded some webinars. There's probably some links to recordings that we've done that we could dig up and share in the resources too, you know, that are just open access. We did put our email address on the bottom or top of our CVI AAC matrix. So, you know, at the risk of receiving 13,000 emails, we will get back to you, but depending on how many emails we get, it may take a while.
That's very generous of you, and we really appreciate it. Sorry, Jen, were you going to say something?
I was going to say, and Dr. Christine Roman, of course, is always available for assessment at the pediatric. Is it still the Pediatric View Clinic?
Pediatric View, yes. So, and Dr. Roman and others do provide consultation, you know.
And she has worked with Sarah, why is her last name evading me, on CVI and AAC.
Sarah Blackstone.
Sarah Blackstone, thank you. So yes, they also have done a lot of extensive work around this topic.
Yes, and you should be able to find materials of theirs, Christine Roman and Sarah Blackstone, including, I think, some even probably archived webinars as well. They talk about a specific approach that they've developed towards informing AAC programs for kids with CVI, which I think is like, I would view it sort of as complementary to ours. I think what we tried to do was provide a super comprehensive list of guidelines of like everything we could think of. Whereas they are looking at more of like an overarching approach, which I think is super important. But yeah, we'll definitely share a lot of resources with you, which can be a starting point. But if you're out there in the middle of nowhere, like, in rural Wyoming or something like that, and you don't have physical access to this, or to people, your state deaf-blind project is usually a good point of reference, at least. Some state deaf-blind projects have more focus on CVI, some have less, because, these are small programs that all, kind of are geared towards the needs of their state and also the expertise of the individuals who work for those projects. But they will, at the very least, be able to point you to the people who are able to support you locally.
And we have a longer presentation on both the Perkins website, as well as if you find the Maryland and DC, our title is Connections Beyond Sight and Sound, is the Maryland DC Deaf Blind Project. On our YouTube page, we hosted this presentation a couple years ago as a summer institute. So there are other longer presentations from us that are out there.
That's wonderful. Thank you both so much for sharing your time with us. I have learned so much from the two of you, and it's very clear that this is kind of a life's work, a whole field of study. And it's abundantly clear how important it is for speech language pathologists to be, at the bare minimum, aware of this and, have access to additional resources. Is there anything else you'd like to share with our audience before we say goodbye and before I try and convince you to come back?
I'd say that, it is a lot of work if you're looking at this from the beginning. It is so much easier to go out and purchase these pre-made kits or something that is already standardized and available out there, and you've got it, and next day you can implement it. But if it's not going to work for the child, it's still a waste of time and money. So on the front end, it is putting in that time and effort to possibly determine unique individualized items or things that work for that child and creating a system. But the goal of the matrix we created was to try and help develop strategies that you can build a system that will grow with the child. So you're not reinventing the wheel at each stage and each level, but as they progress, that system that you've already put in place will grow with them and develop with them, and be able to see the success in the student, both in vision and in communication.
And then I couldn't agree more. I'm glad you said that part about systems that grow with kids. And if you look at the CVI AAC matrix, you're going to see that. You're going to see sort of modalities as they grow with a child's communication as well as with a child's vision. That's a super unique thing about CVI that I neglected to mention earlier, is that one of the key differences between CVI and ocular forms of visual impairment is that kids with CVI should be expected to make progress in their visual functioning over time if they have the right interventions and the right experiences with vision, because their brain is still growing and processing visual information. That's not true of kids with ocular visual impairments who either have static vision, it just is what it is, or else they have progressive loss of vision. With CVI, we're actually working with kids to improve their vision over time. The very, very last thing I'll say is just to re-emphasize the importance of collaboration, and how I really don't think that I've ever seen a sort of quote unquote perfect AAC program for a kid with CVI. And that's because I don't think it exists, because the best that we can do is to find a balance between the language and communication priorities that are usually the role of the speech pathologist and the visual access priorities that are usually the role of the TVI. We've got to find a balance between the two to create the most accessible program. It's never going to be perfect for you as a speech pathologist. It's never going to be perfect for the vision provider. It shouldn't be. It should be a constant kind of push and pull to maximize both at the level that the child can handle.
Excellent. Thank you so much. This really was this was a great episode. This was so wonderful. And we're so grateful for your time. For anybody who is listening, all of the resources that we mentioned will be linked in the show notes. Jen, Chris, thank you again so much for being here.
Thank you so much.
It was awesome.
Thank you both so much.
Thank you so much for joining us in today's episode. As always, you can use this episode for ASHA CEUs. You can also potentially use this episode for other credits depending on the regulations of your governing body. To determine if this episode will count towards professional development in your area of study, please check in with your governing bodies, or you can go to our website, www.slpnerdcast.com. All of the references and information listed throughout the course of the episode will be listed in the show notes. And as always, if you have any questions, please email us at info@slpnerdcast.com. Thank you so much for joining us, and we hope to welcome you back here again soon.